Chronic kidney disease. So CKD, chronic kidney disease, is a irreversible process with a little asterisk, the asterisk being after stage 3. So when we talk about AKI, there's pre-renal, intrarenal, post-renal. When you talk about chronic kidney disease, you stage it in 1 through 5, right? Classically, it was this GFR, and they've kind of upgraded from this GFR clock to this table in the corner here, where they're looking at, yes, GFR, but they're also looking at how much albumin is being secreted. They're also looking more at creatinine, so it's called the creatinine-to-albumin ratio. Not the albumin in the serum, but the albumin that they're peeing out of their glomerulus, right? So glomerulus is getting destroyed and destroyed and destroyed, and it's not doing what it's designed to do. What's the glomerulus designed to do? Filter, right? So the glomerulus is going to filter everything except for 2 things. What are the 2 things? One thing is albumin, right? So albumin should not be in the urine. What else should not be in the urine? RBCs. Blood should not be in the urine. You should not be peeing blood right now. If you are, please consult a professional, right? So you also, if your urine is super, super foamy, that means you have super, super amounts of foam, yes, but super, super amounts of albumin, right? So albumin makes urine foamy, and of course, blood makes it bloody, right? So GFR was classically how we looked at this, but there's a little clock here, so you have like 12 at the top, so greater than 120, that's what they calculated based on the little formula right here, based on your age, your gender, your serum creatinine, and they also have like an African American derivative, but it's not validated. Like I mentioned before in AKI, it's for someone who has like no kidney function at all, like out of the lab, like the kidneys are gone, removed, then you could associate it with creatinine. But someone in the hospital setting, it doesn't really matter as much. Maybe you can apply it on the outpatient side over like 3 months or 6 months or so. Look at the creatinine changes over time. But what's going to get you the most bang for your buck is if they have albumin in the urine, right? They have proteinuria. And you can detect little precursors to albumin called microalbumin. It's something they can look as well. That tells you how bad someone's kidney function is. As the protein goes up in the urine, so does the damage to the kidneys, the damage to the nephron, right? And then of course, you don't really get blood with chronic kidney disease, but yeah, that is something that there's other causes of glomerular damage that could cause blood to be in the urine. Right, so the higher stage though, and we do stage based on the GFR, so that still is around. But stage 5, that is what? That is need for each HD, need for hemodialysis or renal replacement therapy, right? So once you are CKD stage 5, don't write down CKD stage 5 on the report sheets or on your little S bars. You automatically cross that off and write down end-stage renal disease. They are at the end stage, right? End-stage renal disease is stage 5, right? If they're getting dialysis, they are automatically end-stage renal disease, okay? And yeah, it depends, because they could have acute kidney injury with dialysis, right? So that could be a reason too. So knowing their history, whether they're history dialysis or not, can let us know where they're at, right? And let us know how sick they are, because someone that's getting dialysis as an outpatient is not as sick as someone who's getting dialysis acutely in the hospital setting, okay? And so albumin to creatinine ratio is the most important way to stage how bad someone is. And again, I think we mentioned in AKI, but once you hit stage 3, it's kind of the point of no return. You can see the plasma creatinine starts going up. You can see the microalbumin starts going up. The urine sodium starts failing, right? Because usually your kidneys hold on to sodium, right? In the presence of aldosterone. But if our kidneys are dying, you're not going to hold on to sodium anymore, are you? And then you can see your renal functions going down. So what's building up? Toxins. What kind of toxins? BUN will be going up, like we mentioned here, right? BUN go up, but also potassium goes up, hydrogen ions go up, right? So we start having these toxic effects starting to occur. Okay, so the nephrons keep going down and down and down, and again, we started with not 100, but 1 million nephrons per kidney, right? So as that goes stage 1 by stage 2 to stage 3 is really that cutoff where we're going to start. It's really irreversible after that point. We can slow the progression down, but the only fix when you're in end-stage renal disease is with a renal transplant, unfortunately. So what are the causes? How does CKD develop? So kind of like with heart failure, when you have too much angiotensin 2 around, too much SNS around, too much action on the heart, it causes the heart to start getting failed, right? Starts to fail the heart, starts to remodel the heart to what it thinks a heart should look like, but it doesn't look anything like a heart when it's done with it, right? Actually cause more harm than good. So all the medication we gave to heart failure were to stop the progression of the remodeling, right? We gave beta blockers, we gave ACE inhibitors, ARBs, we gave spironolactone, we gave all these things to stop the remodeling. And we'll find out that's really the same thing for the kidneys. When the kidneys are damaged, right, because why were they damaged? It was because we had like hypertension, right? Hypertension came through, it started doing donuts in the parking lot, whoop, 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 and it's starting to literally eat away at the glomerulus and causing holes in the glomerulus. And we want to, and then the aldosterone and the angiotensin 2 and all and SNS coming. I know how to fix that, and they don't fix it the right way. So it's going to actually cause more damage in the end, right? So we want to stop this remodeling of the arterioles and also remodeling of the glomeruli, especially with like hypertension. So that's the idea, is to stop that progression as much as possible. And what caused that to happen in the first place was the diabetes, was the hypertension. And other nephrons start working harder than other ones. They start getting more flow that they're not used to, more workload that we're used to. So they start getting swollen and starting to get stretched and broken and inflamed. And it's a snowball effect where they keep getting damaged and more damaged and more damaged. And then guess who comes to save the day is the old X, SNS, and angiotensin 2. It's like, I know how to fix you. Come with me. We're gonna fix you up, and we're gonna make you all whole again, right? But they're actually making it more holy by causing more glomerular damage. Okay, so what's doing this in the first place? Diabetes. That's the most common reason for chronic kidney disease. Although going back, as we talked about at the end of AKI, is they have they have pre-renal, intrarenal, post-renal failure, and that you can end up with a fully healed kidneys, or you can end up with chronic kidney disease or broken kidneys. So an important important cause of chronic kidney disease is AKI, right? So we got to prevent that. Oftentimes patients come in with acute on chronic kidney disease. They had stage 3, but now their creatinine's gone up from their baseline, right? And that can put them then spit out of the hospital at a higher stage than when they came in. But if they were just like, they have been to the hospital a little bit, diabetes uncontrolled can cause a chronic kidney disease, and it's one of the most common reasons for your kidneys to fail and to require dialysis. What it's doing is it's disrupting, you're getting all this glucose around, and you have certain cells that can handle that glucose. They can break it down, eat it apart, and then go ahead and spit it out into something that is not going to be toxic, right? But certain cells don't do that. So like the cells of the eye, right, and the cells of the Schwann cells and our cells of the glomerulus, the podocytes, can't break down glucose all the way down. It breaks it down a little bit, but it breaks it down into something that still is osmotically active, still can pull water into it, and therefore burst it and rupture it. So it causes more damage to nerves, eyes, and kidneys compared to other organs. Right? And of course, it crystallizes the vessels of the body and makes it so that the vessels can then get laden with atheromas, and that will then cause hypertension, which is our second reason for chronic kidney disease. So if someone has diabetes and hypertension, that's going to really escalate their chronic kidney disease into full-on end-stage renal disease. So, but hypertension alone, right, just with a high salt diet, with ASCVD, which is another significant side effect or significant American way of living, is all the atheromas that are put as a high risk for hypertension and diabetes as well. And of course, we can get ASCVD independently if we are obese, and we have metabolic syndrome, which we talked about with ASCVD back in cardiac. But smoking puts you at risk as well. That causes hypertension in and of itself. It vasoconstricts. It's also an inflammatory piece, right? So it inflames your vessels and makes it so that atheromas can now develop on those broken down vessels, right? And then CHF. So CHF, we can't pump the blood forward to the kidney, right? We can't pump the blood forward. It's all going to back up into the kidney as well. So those two things together are what cause a kidney to fail. It's not getting perfusion chronically, and it's being congested chronically, and that's going to cause my kidney to fail. Okay, so CHF, unfortunately, is a result of ASCVD, is an effect of hypertension, and is a sequelae of diabetes. So this is all intertwined as far as what leads to chronic kidney disease. And these are only the vascular reasons. There can be other reasons, such as you have a infectious etiology. Glomerulonephritis caused AKI, but it can also be like a chronic issue. They have like lupus, right, as a systemic lupus erythematosus, right? That could cause a constant breakdown and inflammation of the glomerulus here, and that's going to cause cause a leakage and cause further inflammation and breakdown and, of course, chronic kidney disease. We're going to get more albumin that's going to start leaking out. The creatinine is going to start going up. We're going to be over here in the later stages of CKD, right? Usually when someone has lupus, unfortunately, they're going to get end-stage renal disease in the next 5 to 10 years, guaranteed. All right, so repeated pyelonephritis, as we know, acute pyelonephritis might just be a one and done, cause an acute kidney injury or not. We try to prevent it. But if you have it chronically, that can cause a chronic kidney disease as it chronically damages these nephrons, right? And then NSAIDs, as we mentioned, were bad for ICU patients, but sometimes patients need NSAIDs, patients with rheumatoid arthritis, patients with osteoarthritis, patients with lower back pain. They're always on ibuprofen or Motrin, and they're on that for a long time. And if it doesn't cause a GI bleed, which is your risk for, it can cause kidney damage because it directly inhibits the vasodilation and flow to the kidneys, to the glomerulus itself. So if you get NSAIDs there, it's going to stop glomerular perfusion, right, over a long period of time. And nephrotoxins over time, NSAIDs and nephrotoxin in and of itself, but as we mentioned, morphine, the metabolite, is damaging the kidneys as well. Antibiotics, usually that causes acute kidney injury, but if you're on it for a long period of time, like some people are on Bactrim prophylactically, like HIV patients, once they have a poor CD4 count, like less than 200, they'd be on Bactrim indefinitely, right? So that can then put them at risk for renal failure or CKD. There's genetic reasons. We kind of touched on polycystic kidney disease. It's actually third place, right? Believe it or not. It's a genetic disease, but it very commonly leads to kidney failure and chronic kidney disease, right? Autoimmune, we touched on, right? Lupus can put you at risk for damaging and more damage and more inflammation of the kidneys, which leads to, chronic kidney disease. So what are your symptoms? So the symptoms, unfortunately, are the complications. It's not as bad as cirrhosis, unfortunately, luckily, right? Because cirrhosis was ridiculous. There was complication after complication after complication. Whereas CKD, it's a little bit more organized. We have general things that you can't really categorize elsewhere, right? Obviously, if I have poor kidney function, I have poor urine output, right? So oliguria checks out, right? I'm going to have poor urine output because my nephrons are dying. They're not able to do their job. Now, if the nephrons can't do their job, they can't get rid of fluid. So fluid overload is a symptom. So they have crackles and auscultation. They have a hypertensive crisis. They have a BP that's over 180 over 120 is technically a hypertensive crisis, right? They get CHF. They don't have it already. They're going to get CHF, right? Otherwise, just that fluid building up can push its way over the capillary pressures and cause edema, whether it be dependent or it be pulmonary, right? So those are symptoms of fluid overload. And yes, they are symptoms of renal failure. We're trying to conceptualize it and box it up as best we can, right? So how do you fix that? Well, you got to fix their hypertension. We have, it's called ACDC therapy, where you start them on ACE inhibitor, you start them on a calcium channel blocker, and you start them on a diuretic, right? So that's the idea with those. And you might pause and say, wait, ACE inhibitors? I thought that was going to cause, vasodilation of the efferent arteriole, of course, sir, right? But no, that's going to cause, yes, you avoid it in acute kidney injury, but you give it in chronic kidney disease. It actually prevents angiotensin II from doing the remodeling of the glomerulus, right? So it's safe for patients with CKD, especially the earlier stages. Once they're getting late stages, they start having more complications to hyperkalemia, so they can't give it anymore. Okay, so it's safer in the earlier stages. For acute kidney injury, someone comes in AKI and they were on this medication because they had CKD, you're going to still hold it because they're now in the hospital setting. They're at risk for hyperkalemia and worsening outcomes, right? So what else you get for fluid overload? You get JVD, jugular venous distension. You get the edema we mentioned. And for these guys, you do sodium restriction. You got daily weights are important because especially like on the floor and they have chronic kidney disease, you can't get great intake and outputs, right? Oh, they avoided ×2. What does that mean? What are they, fluid overload or not? Was it 200? Was it 100? Was it 400? I have no idea how much void times 2 is, right? But weights don't lie. So you took your weight yesterday and you're 72 kilos. I take your weight today and you're 74 kilos. How much fluid did they gain? 2. 2 what? 2 kilos, yes, but 2 how much fluid? 2 liters, right? 1 kilogram is equal to 1 liter, right? So they gain 2 liters, or 2 liters positive. And then we can say we give diuretics, let's see how they do, right? And then you come back the next day and they're 74 kilos, diuretics didn't work, right? It says void times 2 still, but that was probably like 40 cc's or 70 cc's, we have no idea. So daily weights that's the reason why they're important, right? And the I's and O's, yeah, that if we have accurate I's and O's, perfect, right? Then we can depend on it. But if someone like drops the ball and forgets to like empty their Foley and chart it, and then the next shift's like, no, I'm not charting that. That was night shift or that was day shift, right? Then we lose out on volume, right? If that keeps happening, then we get a bad trend. But we can see the trend over time. And again, the daily weights don't lie. Okay, so hypertension is a complication of chronic kidney disease, because also we can't get rid of those, the angiotensin 2 can't get rid of, the SNS we can't get rid of, the kidneys are not getting the flow it needs, and so it's going to stay with the RAS more, and that's kind of why the ACE inhibitors are beneficial. Okay, and then next we got hyperkalemia. We can't get rid of toxins such as potassium. So you can't get rid of potassium, your potassium goes up, and if your K goes up, what's another consequence of that? Acidosis. And if you can't get rid of hydrogen ions, you're going to get acidotic. And you get acidotic, you get hyperkalemic. If you get hyperkalemic, you get acidotic. So these guys are kind of hand in hand and stuff we've got to be really paying attention to. And if they are getting hyperkalemic, we have agents we can give. And we'll talk about the mnemonic for that. As you know, detectives are called dicks from the 40s, right? So it's a big detective is the mnemonic for the cocktail you give for someone that has a hyperkalemia. And we're going to do as much as we can to fix it, right? We give A for albuterol, B for beta agonists, right? H is for hemodialysis, C is for calcium chloride, calcium gluconate, K is for we don't do K-oxalate anymore. We do K for crapping it out, right? These are the way things we do to get rid of potassium. And we'll spend a second on that, right? But what happens when you get hyperkalemic, we get acidotic. You get acidotic, you get bradycardic PEA systole, right? So, and of course, hyperkalemia is a side effect of acidosis, right? And the symptoms, you can definitely pay attention to the EKG to make sure we don't have EKG changes of hyperkalemia, but also making sure we're not having, episodes of bradycardias all of a sudden as our membrane potentials get destroyed, okay? So how do you know someone is acidotic? ABG will tell us, and as we mentioned, the CO2 on the chemistry, so the BMP CO2 will also is the bicarb, right? And they'll have what's called a HAGMA, or a high anion gap metabolic acidosis, and we'll talk more about that in our next section. Okay, and then what else? We're going to avoid other acids that will kill them, and we'll talk about those acids, right? There's K for ketones, I for ingestions, L for lactic acid, and U for uremic acidosis, or further kidney failure. Okay, and then what else do you want to get rid of, or should we get rid of? We should be getting rid of BUN, right? If we can't get rid of BUN, it builds up, and you can't just say they have hyper blood urine nitrogen anemia. That doesn't make sense, and people didn't like that, so they called it azotemia, right? So that makes perfect sense, right? It's the same letter, starts with the same letter, but I'm kidding. So azotemia is just a buildup of nitrogenous products, right? So azotemia is elevated BUN because you can't get rid of it. And come to find out, BUN is what's called non-polar, so it goes in and out of membranes just at will, and it can go in the brain and cause ALOC, or comatose state, seizures. It can go into the skin, causing uremic frost. It can go to the heart and cause a pericarditis. It can go to the vasculature and cause endothelial damage. It can go everywhere, okay? And we'll talk more about that as well. And then what else? It can disrupt platelet function too. So then your platelets don't work. So oftentimes these patients, before they get procedures, they get a little dose of DDAVP. Remember, that's our ADH and witness protection. All right, DDAVP is just, yes, it's going to vasoconstrict, and it's going to reabsorb water in the distal coupling tubule, or just collecting duct as such. But it also activates factor 8 and von Willebrand's factor in the endothelial lining, so that you have better platelet function. Okay, so what else does the kidney do? So it has, how many functions does the kidney have? Does it have as many as the liver? Liver had how many functions? More than 500. but our kidney has, good job. It's going to filter things. So filter, one, right? And you can maybe say that's maybe three functions because it filters, reabsorbs, and secretes. But that's like one generic function. That's what the nephron does. What else does the kidney do? It's going to go ahead and it's going to make acid-base balance. Yeah, that's what kind of the filtering piece was, right? And then what else to do? RAS, which is the RAS system, okay? So there's renin in there. So there's a RAS system there, aldosterone involved. It's also going to do, it does vitamin D over here. So parathyroid, post-pituitary, I thought I had it here. Oh, there it is. 1,25-dihydroxycholesterol. That's vitamin D. All right, so it's going to activate the final pathway of vitamin D. It makes vitamin D active. So if you can make vitamin D in your skin, you activate in your liver, and then your final activation is in your kidneys. Your kidneys don't work, vitamin D doesn't work, right? And the other function is erythropoietin, or EPO. What's EPO for? It's what stimulates the production of RBCs. No EPO, no RBCs, right? So EPO goes down and down and down because it can't make it from the kidneys. They should have just given that job at the liver. We wouldn't be in the situation we're in right now, right? But we get anemic here, and if we're anemic due to low EPO, that's going to cause us to be low RBC issues, right? And we'll talk more about in hematology, but you're going to be fatigued because you don't have RBCs to your muscles. You're going to get pale because you don't have RBCs to your skin. You're going to have chest pain because you don't have RBCs to your heart. You're going to get short of breath or dyspneic on exertion because you're going to run out of energy that you're used to having, like a hemoglobin of 14. You have a hemoglobin of 8 instead, right? Once it falls below what number do we have to transfuse them? 7. So less than 7, right? That's going to be where we would transfuse these patients, right? And we'll discuss hematology why we would not give higher because there's a lot of complications that happen with transfusions, right? And then they'll get iron supplements, and to help iron supplements, vitamin C is what's used to help absorb that, okay? And then vitamin D, back to the vitamin D story. So vitamin D is involved, that's what tells your gut to absorb calcium and phosphorus. No vitamin D, you can eat all the calcium you want, and it's not going to get absorbed, right? You have to have vitamin D there. So you have to give PO vitamin D to make it work, right? Or maybe some injections of vitamin D. And then also there's the phosphorus situation. We talk about phosphorus and how it likes to scoop up all the calciums. So that's why you have this inverse relationship. You have a phosphate that's high because you can't get rid of it, and you have a calcium that's low. Well, if I can't get rid of calcium, why is that not low? Right? Because then there's also something else that comes into play, which is parathyroid hormone, which is its job is to raise your calcium. So I know how to raise calcium. I'm just going to break down bone. If I break down bone, calcium phosphate gets going in the serum, but then it's going to get neutralized by all the phosphate. So you're getting phosphate you can't get rid of, and you're getting phosphate added to the serum because you're breaking down bone. So what wins is high phosphate and low calcium. Okay, so we'll talk about what happens with elevated calcium phosphate. So really what we do here is just treat the underlying problem. They have ASCVD, fix the ASCVD. They have CAD, fix that. They have hypertension, fix that. They have diabetes, fix that. They have CKD, we can fix that as well. That's where we have our ACE inhibitors and Arbs, which are going to be critical at stopping the ventricular remodeling that's progressing our CKD, making it worse. So statins are also prescribed because you also have a risk of ASCVD. If it wasn't bad enough that you had ASCVD that caused CKD, that caused chronic kidney disease, you can also have you can't get rid of lipids. If I can't get rid of lipids, that's going to make my lipid count go up, right? So you can have elevated lipids, put your risk for ASCVD, hypertension. Now we're back to square one. Now we're actually progressing our CKD even more because we're causing the risk factors for CKD in the first place. And the only way to fix this is to fix, the complications, but to do dialysis will be the end result, especially after stage 3 CKD. And then renal transplant is the only other option to get someone, not fixed, but get someone corrected as best they can. And when you do a renal transplant, it's actually palliative. It's not curative. Like a liver transplant, the liver can regenerate, right? You just give a lobe of liver to someone else, and they'll make their own liver out of that liver, right? But if you give someone another kidney, that kidney is going to get assaulted with their hypertension, their diabetes, with their ASCVD just as much, right? It's just only a palliative way to fix someone's complications.